Bit of advice I gave to Ash before he came up here was, don't worry mate, you're going to nail it, and he did. I also told him don't set the bar too high. Unfortunately he did. So I'm going to need a bigger ladder, but I'll try and see how we go. Talk to you about afferent limb failure. Afferent limb failure has been known for quite a while now, but it still remains a challenge for us all. The afferent limb is one of the 4 limbs of the rapid response system. It involves the detecting of clinical deterioration through predefined criteria, and then based on those criteria triggering a predefined escalation response. Look, it's common. It's consequential, and it can affect rapid response team performance measures and efficiency. And now that most of our systems have multi-tiers in their response, it's not just limited to the rapid response team. Probably all familiar, there's a range of facilitators and barriers to the afferent limb. Certainly having a hospital culture which is supportive of a rapid response system, the policies that underpin it, good education with respect to safety, quality and the rapid response systems amongst the ward staff are all factors that are known to facilitate the workings of the afferent limb. And in contrast to that, having a hospital culture which still confined to silos, bad experiences with the rapid response team or at a rapid response team call, a perception that the rapid response team adds increase to your workload, they're all obvious barriers to the afferent limb and contribute to afferent limb failure. And even if you are a fan of the rapid response system, you're still at the coalface when it comes to looking at patients who potentially are deteriorating. You can raise your doubts when someone's got a criterion or a trigger for escalation, but they look good. Or someone's got a trigger for escalation and you shouldn't escalate them. You should be heading towards differences in goals of care. So all of those create conflicts and contribute to afferent limb failure. The vital signs and the triggers, they provide a challenge to us with respect to the afferent limb response. And us as sort of kind of providers of the rapid response system, as supporters of the rapid response system, and even within critical care, we sort of kind of compound the issues for the ward staff. We all apply different weightings to the triggers. For example, how often have you heard, well, they've always been a little bit hypotensive. This blood pressure is not that far off their normal. Their saturations have never been higher than this. So we all kind of have different weightings to the triggers, and then we kind of espouse the theory that deterioration is predictable, but it really kind of isn't predictable. And we looked at the prevalence and the incidence of triggers in the 24 hours prior to an event. And we've got a 3-tier response where the nurse is the lower tier, the MDT or the home team view is the middle tier, and then we've got the rapid response team tier. And then criteria that go from nurse, MDT to MER were almost as frequent as the pattern of going the other way around. So there wasn't if you look at all the documentation that's out there on the ward vital charts, there isn't a clear pattern for deterioration in most of the circumstances. And then from a critical care perspective, we often contribute to the problem. So we discharge patients to the ward with criteria. We review patients in the ward with criteria and leave them on the ward, and then that leaves the staff in a conundrum when certain triggers come into play. So the Commission, within its standards, has set up a couple of defences to afferent limb failure, having a core set of vital signs, having a monitoring plan, having a structured tool on what you recall your vital signs, and encouraging a graded response. I thought to be sort of strategies that potentially could minimise the occurrence of afferent limb failure. So how good are all of they? Well, if we look at our vital signs and our triggers, regardless of what sort of system you use, whether you use an aggregated system or a single parameter system, they haven't got a very strong face validity. And that creates a bit of a challenge for ward staff. It puts them in a bit of a conundrum in terms of knowing when to escalate and when not to escalate. Or I guess they know it's a matter of what they feel comfortable with and when to start to use their judgment. Potentially an electronically generated, electronically derived system or electronically validated system may be better than the existing systems that we have now. And what about our monitoring plan? So there's been a few studies out there that have looked at continuous monitoring and intermittent monitoring. And to date, the evidence for continuous monitoring is still quite ambivalent in the ward setting. Continuous monitoring increases afferent limb failure rather than reduce it, and doesn't necessarily reduce your subsequent patient adverse events. And even if you increase the frequency of your intermittent monitoring, a similar sort of finding comes through. You increase your rapid response team calls, you increase your afferent limb failure, and not always necessarily associated with improved patient events. And the patient population that you apply that sort of increased monitoring frequency to is also kind of relevant. If you apply it to low-risk patients, the likelihood of picking up any deterioration is small, and the likelihood of them deteriorating is small as well. So, we're sitting there monitoring patients who are low risk. Some of this might be about 50% of our existing inpatients, hoping we'll pick up some sort of deterioration. And all this activity, kind of increased monitoring, increased rapid response team calls, goes to augmented workload. That creates a bit of conflict, and then goes on to beget non-compliance. And again, interestingly, electronic patient surveillance systems with their own decision support and automatic triggering have been shown to increase rapid response team calls. They haven't kind of measured what their impact is on afferent limb failure, but have been shown to increase rapid response team calls in association with improvements in patient outcomes. So then we have our structured tool, our observation chart. And we looked at this in our institution, and clearly it improves documentation. It probably even improves the number of vital sign parameters that are documented. But we found that in our institution, it increased rapid response team calls quite significantly, but it didn't kind of result in an impact on the basic performance measures. So our downward trend in deaths, downward trend in ICU admissions, and downward trend in cardiac arrests over time didn't alter. That trend still continued. So the structured observation chart didn't have an impact on that, even though it increased our calls substantially. And graded response. So in our institution, we have 3 tiers of response. We've got a nurse tier, a home team tier, and the rapid response team tier. And as you would expect, the nurse-related triggers are a lot more prevalent. They made up almost 70% of all of the triggers. And interestingly, they weren't modified much. They weren't called much, and so in essence, they had a very high afferent limb failure rate as compared to what it was for the rapid response triggers. So the lower tiers, they're common triggers. They make a lot of noise. They don't generate a lot of calls as they should be expected to generate, and so they've got a very high afferent limb failure. And the consequences of that afferent limb failure is not well defined, but it's there. And if you look at the triggers that are most prevalent, they're the ones that are most likely to also result in afferent limb failure. And the most prevalent triggers are also the ones that are most likely to be modified, and they're the ones that are also most likely to have afferent limb failure. So in essence, the way we set up our tiers can potentiate the way the magnitude of the afferent limb failure and potentially consequences of the afferent limb failure. Graded response has been looked at by some other centres as well. They've also documented an increase in the non-rapid response team escalation calls, and they've also noted that there's been a spillover increase in rapid response team calls in association with all of that. Also, the other studies have documented a higher rate of afferent limb failure in the lower tiers without necessarily an improvement in patient outcome. So you've all probably are familiar with alarm or alert fatigue, so I'll just walk you through it. Alarm fatigue effectively occurs when staff are exposed to many alarms. Particularly if those alarms are potentially avoidable or non-actionable. And this in turn leads to a delayed or an inadequate response to those alarms. And adverse patient consequences. It generates a little bit of conflict. How many times have you wanted to thump the monitor? That doesn't work. If you drop it, that works, but then that gets you into trouble. And so what you simply go and do, you just go and push the alarm silence button and turn your back and you kind of override it. And if you have kind of look at that pattern, you kind of think to yourself, well, is that afferent limb failure? And it's sort of it is. It kind of mimics what happens with afferent limb failure. So what are some of the potential solutions to afferent limb failure? Well, we could start identifying what are our high-risk patients, right? Where's most of the money here? And put most of our efforts in there. So increase the frequency monitoring and then maybe put them on continuous monitors rather than put some of the low-yield patients. Can we identify our high-risk patients? Well, we can. There's reasonable studies that out there that have shown that you can identify a high-risk patient at the time of the hospital admission and identify them during the time of the hospital admission. So at the time of admission, those with pre-existing clinical risk factors like advanced malignancy, myocardial infarction, frailty, cognitive impairment, they're not the ones you kind of want to have a rapid response team called to, but you can differentiate those early, go down an alternative pathway for them, and start to reduce your calls and your false alarms, in essence, in that group. And then there are other patients that you can identify from being at high risk. You can combine demographic data, laboratory data, there's clinical scores, and even putting down a clinician intuition score is useful in identifying patients at high risk of deterioration. During the course of the stay, the sort of patients that have had a rapid response team call already, those that have had an episode of failure to rescue, those that have had a prolonged hospital stay, they're all at risk of clinical deterioration, and maybe we should be putting the spotlight on them a little bit more. Other potential solution, well, we know education, training and awareness has worked in the past and continues to work. If we go into the physiological monitor paradigm with alarm fatigue, then maybe we can look at strategies whereby we can get an alternative response to rapid response team other than just when the alarm gets sounded. So for some of these patients, maybe all they need is a bit of an acute palliative care team to respond to them. Maybe they can have a senior critical care trained nurse to see them first, screen them from respect of a rapid response team call. I mean, these are strategies that haven't been tested yet, but they're potential strategies that could reduce the overall alarm and alert burden. We need to be a little bit cautious, though, when we start to silence the alarms or change the thresholds to the alarms, because even in the physiological monitoring world, when they're purely reducing the alarm quantity or the alarm volume doesn't always equate to a reduction in alarm fatigue. So that link hasn't been well established. So if we work on reducing our alarm alert quantity, we just need to be cautious that it doesn't have any adverse consequences as a result. And clearly having an integrated approach is better than a single approach. I think where most of the money will be is within looking at our electronic systems and the information that we kind of get from our electronic health records. So they can help establish for us some more accurate and even some more sophisticated triggers. And if you think about it, for all the hospitals out there, including ours, that are working on a single parameter which is very much aligned to the old-fashioned MET criteria, the MET criteria came out back in the 1990s. The case mix in the hospital has changed over that period of time. So maybe it's time that we looked at those criteria. Maybe it's also time that we looked at criteria based on local case mix. To make those criteria more specific to the environment that we're kind of working in. And so clinical decision support systems will allow us with real-time tracking and real-time alerting. And they also those sort of systems also have a learning aspect to them. Okay, you can look at your previous MET call or previous MET call activity in each individual patient, and you can learn from that, and that can readjust and make your next response a lot smarter. And potentially we could have more real-time reporting on afferent limb and its consequences, and use that as a quality measure to be able to go and address it. Finally, resourcing is really, really important. Our activities increasing. As Ash highlighted to you, everyone else is doing other work other than just running around to MET calls. That provides a real conflict there, and then those conflicts result in other sort of workarounds, and then those workarounds beget afferent limb failure, and that afferent limb failure has adverse patient consequences. So I think all our institutions need to look at the threshold level of our activity that justifies having a standalone team, and we recently did that in our institution, and we've had quite significant positive and measurable benefits for the staff and for the patients in our workload, and how the rapid response team is being viewed within our institution. So in summary, the for the rapid response team, the afferent limb failure is common and it's consequential, but significantly so it's more common in the lower tiers. We don't quite know what the consequences of it is in those lower tiers, but the assumption is that there are some consequences to it. The existing criteria and our monitoring strategies, as well as some of the structured tools that we use, may not have had a mixed impact on afferent limb failure and may not be our sole solutions. And we really need to be looking now into what the electronic health records, what some of the decision support systems can allow us to achieve within that area of better identifying the clinical deteriorating patient, managing the alarm fatigue concept to it, getting rid of some of the human factors that create problems and begets afferent limb failure, and with it, hopefully, generating some more improved patient outcomes.